Welcome everyone to the MS Focus. It's like a town hall with Dr. Aaron Boster tonight. So I hope you have a lot of questions ready to go. You can put them in the Q&A section, please. You can also raise your hand if you'd like to ask directly. But let's get started because we got a lot to talk about tonight. Dr. Aaron Boster is a board-certified neurologist specializing in multiple sclerosis and related CNS inflammatory disorders. He decided to become an MS doctor at age 12 after he watched his uncle Mark suffer from the disease in a time before there was treatment available for MS. Dr. Boster grew up in Columbus, Ohio, and attended undergraduate at Obermann College, and he earned his MD at the University of Cincinnati College of Medicine and completed an internship in internal medicine and residency in neurology at the University of Michigan. He then completed a 2-year fellowship in clinical neuroimmunology at Wayne State University. And then, or since then, Dr. Boster has been really involved in caring for people impacted by MS. And he's a principal investigator in a number of clinical trials, trained multiple MS doctors and nurse practitioners, and he's been published extensively in medical journals. And he lectures to both patients and providers worldwide on a mission of educate, energize, and empower people impacted with MS. And he's an amazing man with his wife Chrissy and son Maxwell and daughter Betty May in Columbus, Ohio. I'd like to welcome Dr. Aaron Boster. Thank you so much, sir.
Oh my goodness, Chris, that was such a warm welcome. Thank you very, very much. It is absolutely delightful that I get to be back with you guys. I've been looking forward to this evening for several days now. We should really have a good time.
All right. And so we have questions in the Q&A already popping in. Now, if I mispronounce something, you can pop up your Q&A if you want to read it directly from there, so I don't have to do that. You probably...
Let me see if I see it. I'll just start going down this list and then
go down the list.
Interject. Yeah. So the first question that we're going to entertain tonight is by J. Sierra, who writes, "How can I reduce my sensory symptoms? I have a constant sensation after an attack 1 year ago. It's inside my mouth, gums, and affects my taste on one side, and my chin feels sore. I already tried gabapentin and Lyrica, and my neuro has not suggested anything else. Should I hold out hope that the lesions will heal over time and then the sensation will be reduced?" So, Jay Sierra, thank you for sharing with us an unpleasantry. I'm really sorry that you had that attack. And what I'm picking up is that a year later, you still are rather affected. And so there has not been a complete recovery of those symptoms. Now, I don't have enough information to really answer your question to the granular level that you want. And so instead, I'm going to make some general comments that I hope are applicable. The first thing is, if you have symptoms of an attack 12 months later, it's more than likely that that's going to stick around. Now, there are exceptions to every rule. But if you have neurological symptoms residual from an attack 12 months later, I think it's likely that that symptom may stay with us, and we're going to need to turn our attention to how we treat it symptomatically. When I say symptomatically, what I mean is we can have a pill for that ill. And in this instance, if we can make those sensory changes dampen or go away, that might be super valuable to you. Now, you share in your discussion of your question that your neurologist has tried 2 neuropathic pain medicines. One of them is gabapentin, trade name Neurontin. One of them is pregabalin, trade name Lyrica. And these are 2 medicines originally invented to treat seizures, which turn out to be very effective in treating MS neuropathic pain. And the good news is it's 2 of probably 25 drugs that I could list for you right now that all treat neuropathic pain. There are a host of medicines, literally, I can think of 20 more, that we could try to see if we can dampen those symptoms. So, do I think that you should hold out hope? No, I think that you should go back to the neurologist and say, hey, Mr. or Mrs. Neurology person, this bothers me and I want you to keep working on it. And if they say something besides yes, then you can say, okay, please send me to a doctor who is competent to make this feel better. Because you have a right to be selfish. It's your face. And I want you to remember that there's a lot of different medicines that we could use that haven't been tried yet. And thank you for that question. Now, maybe we'll just go down this list until my moderators tell me to do something different. And the next question is coming from Deborah. And she writes, have you found any effective disease-modifying therapies to treat secondary progressive MS for patients with no discernible relapses, remission, and new lesions? And the answer is absolutely. So medicines, particularly the newer medicines, do much more than just shut down new attacks and new spots on the MRI. They are remarkable in many cases at decreasing disability progression. As an example, we have a B-cell depleter that is so effective in progression, it actually can slow primary progressive MS. And that's pretty impressive. Any of the medicines that treat relapsing MS have an impact beyond just treating relapses. And it's my strong opinion that secondary progressive MS isn't actually real. It's just part of the spectrum of relapsing disease. Because somebody who has so-called secondary progressive MS is still at risk of having attacks. They're still at risk of having new spots on their MRI. And they're at risk of having disability progression. A newly diagnosed relapsing patient is at risk of an attack in a new spot, and they're actually at very high risk of that. That newly diagnosed relapsing patient is also at risk of progression, but less so earlier in the disease. So in my mind, the concept of secondary progressive MS does not provide any value to my treatment paradigm. I would love to see you on the most effective disease-modifying therapy you're comfortable with. Not because we're desperate to shut down attacks, because you're not having lots of those, but to slow disability progression and, importantly, to slow brain volume loss. And we definitely have drugs that can do that. So thank you for that question. The next one comes from Joanne, who writes, hello. Well, hello, Joanne. Thank you very much for joining me tonight. She writes, my body created anti-Tysabri antibodies. Does this mean that my body won't tolerate any MAB class of drugs? Now, this is a fantastic question. And the quick answer is no. So when we talk about monoclonal antibodies, and when she writes the word MAB, she's referencing monoclonal antibodies. These are infused biologic agents. So to give you some trade names, Tysabri is one, that's natalizumab. Ocrelizumab is Ocrevus, that's another one. Rituxan is one. Ufatumumab, that's Kesimpta, that's one. There's a bunch of them. Alemtuzumab, which is Lemtrada. They're all monoclonal antibodies. And I understand why you say they're a class of medicine, because they all work by creating these antibodies, but each antibody is very, very different. And if you were to develop anti-Tysabri antibodies, it will only impact Tysabri. It has no bearing on any of the other monoclonal antibodies. And so fortunately, those options are not shut down. They're still available to you. Now, the one thing that I can say with certainty is if you have anti-Tysabri antibodies, it's not the best move to stay on Tysabri, because you still have risks of Tysabri, for example, like a risk of PML, but you don't have the clinical benefit because your body is turning the drug off. Excellent question, Joanne. Thank you very much.
Dr. Boster, I just wanted to welcome those who came, who just are arriving, and to invite them to put questions into the Q&A for Dr. Boster, and keep asking away. Thank you for diving right in.
Yeah, and thank you guys. This is such an awesome opportunity to spend some time with you, and I love these questions. Yeah. So the next one comes from Kelly, and she writes, how do you know when you have, wait, it just moved on me. How do you know when you've gone from relapsing MS to secondary MS? And so that's a very appropriate piggyback question off the last one that we just talked about. So someone with MS who has a relapse has a relapsing form of multiple sclerosis. Relapsing forms of multiple sclerosis include clinically isolated syndrome, relapsing MS, and so-called secondary progressive MS. And you can't draw a line in the sand when someone clearly has progression. You can really only sort that out by looking backwards. So someone who is likely to have secondary progressive MS has not had an MS attack in some time and has had some disability progression completely independent from attack. Typically, we would expect it to include some motor deficits. And so the thing that I want you to take away is not, oh, I have relapsing MS or, oh, I have secondary progressive MS. On the contrary, it's a spectrum of the same disease, in my opinion, and the treatments are still applicable. So that was a great question. Thank you. Let's see, there's another question from a Joanne. My neurologist stated that I had primary progressive MS, but now, so I have tumefactive MS. What is tumefactive MS? And what treatment is best? So tumefactive is a word, which is Greek, I think, and it means like a tumor, but it ain't. So when you look at an MRI and there's a spot on the MRI, if it looks really swollen and it's taking up a lot of space and there's fluid all around it, and maybe it lights up when you give contrast, and it's kind of an angry, big looking lesion, we describe the lesion as tumefactive. It's actually a pathologic description. We say it looks like a tumor, but it isn't. And when someone has tumefactive lesions, sometimes they'll say we have tumefactive MS, but tumefactive MS is not a type of MS. It's a description of some of the way the lesions look. So we don't have a separate treatment paradigm to treat tumefactive lesions. Now, I'll tell you something, Joanne, which is weird, but fantastically wonderful. Tumefactive lesions prognostically are less concerning than small lesions, believe it or not. Now, it wouldn't appear that way because they're really big and kind of scary looking, but interestingly, when you follow them prognostically, they're not as concerning. So thank you for that question. The next question comes from a fantastic gentleman, a guy named Joseph Siders. Joe, I hope you're doing well. And he comes with a fantastic question. I'm not surprised. He says, what's the current news on BTKs? So he's talking about routine tyrosine kinase inhibitors. And these BTK inhibitors are a class of medicine which are approved by the American FDA to use in cancer treatments. And it turns out they look like they're probably the next big thing in multiple sclerosis. Now, these are pills that you take. And what the BTK inhibitor does is two things that are really special to me. Number one, it blocks B-cell communication without murder. So we learned a couple of years ago that it's a really effective way to treat MS to give someone a medicine that depletes their B cells. But there's a problem of risk of infection when you do that. These BTK inhibitors suppress B-cell communication, like plug their ears so they can't hear, la, 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 but they don't kill the cell. And that's pretty slick. The second thing that BTK inhibitors do that I'm very excited about is they can cross the blood-brain barrier in some cases, and they can turn off these innate immune cells in the brain called microglia. And so that's really, really exciting because we don't have any drugs in the armamentarium that can do that. Now, Joe knew all that already. His question wasn't what is a BTK inhibitor. His question is what are the updates in BTK inhibitors? So right now, there are multiple manufacturers that are aggressively studying BTK inhibitors. So Genentech, Sanofi, Serono, Novartis, and soon Biogen, they all have BTK inhibitors. And they're all currently enrolling clinical trials where we're studying them. At this point, Joe, we don't have a readout in the phase 3 data. We have the data from the phase 2 that we already saw, but right now we're in the process of enrolling patients and running them through the trials. The trial that is the farthest ahead is evobrutinib, which is a trial run by the manufacturer Sanofi, which is a subsidiary of Merck in Germany. And they have completed enrollment to their trial, and they are running the trial. It's going to go for a couple years. Now, the second position is taken up by Sanofi, and they have a product called telobrutinib, and its relapsing trial is close to enrollment, and they're moving forward. And so it's too early to get a readout, and we're probably not going to get a formal readout for another couple years. But as we learn things, I will definitely update you. And I appreciate you asking the question. The next question comes from Zoom user. And Zoom user writes, I have PPMS, and right now I only have limping and weakness in my right leg. Is this normal in PPMS? Does it get more severe as time goes on? I'm in a clinical trial for PPMS, and I'm getting excellent care. Well, first of all, Zoom user, I love your name. Second of all, thank you for participating in a clinical trial. And I really want to tell you why I'm thanking you for a second. When my Uncle Mark had MS, there were 0 drugs to treat him. And so I, as a child, got to watch the natural history of MS, which is a terrible way of saying I watched him deteriorate before there were therapies available. Today, we have 27 different formulations of MS medicines to treat people impacted by MS. And we can thank people with MS who came before you, who volunteered their body to answer the questions. Think about it. If a manufacturer has what they think is the most amazing new thing, this magical pill, and they don't have a person with MS to test it on, they'll never figure it out. And so if 0 people with MS volunteered for clinical trials, we would have 0 drugs available to offer them. Now, here we have someone with primary progressive MS who is involved in a clinical trial. And Zoom user, thank you very much from the entire MS community for your willingness to fight back and to help us figure out the next best thing. Now, the question is, I'm limping in my leg. Is that normal? And is it going to get worse? So one way of describing primary progressive MS, if I use neurological jargon, it's a progressive myelopathy. So what the heck is a myelopathy? That's like a Scrabble word. Myelo is Greek for cord. Opathy means it don't work so hot. So myelopathy is Greek for there's a problem with your spinal cord. Progressive means that it changes over time and gets worse over time. And primary progressive multiple sclerosis has a tendency to impact the spinal cord and to worsen over time. Are you doomed to not have that leg work? No, I'm not telling you that at all. I'm simply saying that the natural history of primary progressive MS is a slow decline, and it most certainly can affect your legs. I am delighted that you're participating in a clinical trial, and I very much hope that it helps you. And thank you for asking that awesome question. Now, the names are getting more and more interesting because earlier we just had Zoom user. Now we have anonymous attendee. Now, think about all the conversations that went into Anonymous's parents' decision to name him that. I mean, they kicked around family names like Joe and Steve, and then they said, no, we're going to go with Anonymous. So Anonymous, thank you very much for writing in.
I was reading it as a non-Y mouse. I don't know why.
Oh, excellent. So it's like a female mouse, a double N. All right. So I started injecting myself with Rebif last week. Do I need to get periodic blood tests? How often and what specific tests should I ask for? So this is an excellent question from an intelligent person that's trying to make sure they're doing the right thing. And the first thing that I would say, I'm going to answer your question 100%, but I definitely feel like there needs to be a conversation with your MS provider because they may have some certain tricks and tips and things that they want to convey to you. But to answer your question more globally about Rebif, Rebif is a drug which is metabolized by your liver. And so it's a best practice to check liver enzymes at least twice, if not 4 times a year, just to make sure that your liver's okay. Because if the Rebif makes your liver enzymes go up, we can stop the Rebif and they go back down. Rebif rarely can mess with your thyroid. And so I like to check thyroid tests twice a year on my patients taking medicines like Rebif. And rarely, very rarely, Rebif can drop your white blood cell count. Now that's very uncommon, but at least once a year, I like to check a white blood cell count just to make sure that we don't have a problem. And so if you got what I call a CBC, which looks at your blood counts, and you got a comprehensive profile that would give you your liver and a couple other things, and then a thyroid panel, that's going to be more than enough to keep you safe. And it's my opinion that doing that at least twice a year is a really good idea. So the next question is by either the same person or another person with the exact same name, a non-Y mouse. And so this question is, what are your thoughts on glutathione injections and NAD injections to combat symptoms of MS? And my quick answer is, I don't have enough information to speak intelligently. And so I don't want to make something up. I'm going to have to admit that I don't know. And that's what I'm going to be looking up later tonight after I get off this call. So thank you for bringing that up so I can learn. The next question comes from someone named Kristen. Kristen, thank you for writing in. Which shot should I do first, flu or COVID? I think there's not enough information to answer your question because I would need to know the timing of your MS medicines and when you last took your MS medicines. Ostensibly, I need you to get both, and you could do one, you can do them on the same day. And so I don't think there's a contraindication to getting COVID and flu at the same time. So I would vote you do both at the same time. Now, a third attendee who has the exact same name as the other two attendees, this is phenomenal, has a great question. So anonymous attendee writes, what are your thoughts on Kesimpta? So Kesimpta, the trade name for the drug ufatumumab, that's a fun name, ufatumumab. Kesimpta is a monthly injection of a B-cell depleter. So it's in the class of medicines like ocrelizumab, Ocrevus, rituximab, and it is a B-cell depleter. And I consider Kesimpta to be a high efficacy medicine that a patient can take with a self-injection once a month. The next question comes from D. O'Connor. And D writes, what strategies for exhaustion after physical activity? No mental exhaustion, but fatigue. So D, thank you for that question. Fatigue is the single most common symptom in MS. It's also the leading cause of loss of work. It's also invisible. And it's really, really frustrating because when you say to your friend or your spouse, I'm tired, they say, oh yeah, honey, me too. Except they don't understand how tired you are. And I really like your question because there's multiple different kinds of fatigue in MS. And one kind of fatigue is a cognitive fog, and you're not having that. Another kind of fatigue is what I call pathologic fatigue, where you're exhausted and trying to get through your day is like, trying to keep your eyes peeled open with like sticks or something. So let's talk about things that we can do to improve physical fatigue. Now, first of all, I'm going to make a shameless plug for my YouTube channel. So if you don't want to hear a shameless plug for my YouTube channel, mute your line or turn your speakers off for the next 3 sentences. So a long time ago, I was frustrated that I didn't have adequate internet resources to refer patients. So I decided I would make one. And so I've been making YouTube videos once every Monday for the last 6 years or something, actually since 2015. So quite some time. I look today, there's 540 videos that I've made. And I have an entire playlist on fatigue because fatigue is a really important symptom. So if you are super bored tonight and couldn't sleep, you can go to my YouTube channel, which is my name, Aaron Boster, and you can look at the playlist under fatigue and you'll see 25 some videos that I've made over the years on different tricks and tips to beat fatigue. But let's share a couple of them now, and I'll just do 5 because I have 5 fingers on this hand. So as long as I do 1 finger, then I'll get them all. All right. So the first one to help fatigue is to make sure that you're getting 8 hours of restorative sleep. So most red-blooded Americans don't budget 8 hours. They go to bed at midnight, wake up at 6 or something like this. So they're cutting off their legs before they even start their day. You need adequate sleep and you need restorative sleep, which means if you're a snorer and you're waking up throughout the night or having apneic episodes, or if you have restless leg and it's keeping you up, we need to treat those things because I need you to get proper sleep. If you're waking up to go to the bathroom 6 times, we got to fix that. Getting restorative sleep is key to having energy during the day. And if you wake up and you're exhausted and your head hurts and you're snoring all night, you have sleep apnea, and we need to treat that. Otherwise, we're never going to get your energy back up. That's number 1. Number 2 is to up your water gain. And if you think I'm lying, I double dog dare you to try it. If you increase your water, you will increase your energy. Seriously. So try it, and then you can text me and tell me how it worked because it always works. So I want gentlemen to drink 120 ounces. That's 6 bottles of water a day, for real. I want ladies to drink at least 5 bottles of water a day. And when you do that, you will find that your energy levels pop up. Number 3, cut out sugar. For real, remove sugar from your diet. Sugar is a poison, in my opinion. And if you remove sugar from your diet, the most amazing thing happens to your energy levels. They skyrocket. And about once every 6 months, a patient takes me up on it and they come in, they're like, oh my God, because it's really, really exciting when they have a bunch of energy. Now, number 4 is to consider certain nutritional supplements that have been shown to help energy. And so I will oftentimes recommend supplements that feed the Krebs cycle. The Krebs cycle is part of the mitochondria. That's the powerhouse of the cell where we make the energy. And so there's some data to suggest that taking supplements like levocarnitine, creatine, CoQ10, those can help feed the Krebs cycle and in some cases can provide energy. Other supplements like B12 can provide energy as well. And I'll finish by saying that exercise consistently improves energy levels in MS. And you might say, are you crazy? Did you read my question? I told you that I was exhausted. Yes, I did read your question. And what I need you to do is very methodically and very slowly increase your exercise endurance. You might start off by just walking to the mailbox and walking back and you're exhausted. Good job. Do that day in and day out until walking to the mailbox is no big deal. Then I want you to walk the mailbox and I want you to take 10 more steps and then go back. Not a mile, just 10 more steps. And very, very slowly over time, we're going to build up your functional reserves. So that was a great question. Thank you for asking it. The next question, and if I mispronounce your name, I'm very sorry. Kamia, I hope that's pronounced correctly. So Kamia Hafiz writes in, I was diagnosed with MS after being hospitalized for a DVT in my right vein. Also, my MRI showed multiple T2 lesions. The doctors at the hospital did not think that the MS caused the DVT. However, based on my research, MS can lead to dysregulation of blood clotting factors. False. Do you believe blood clot was caused by MS? No, I do not. And MS does not increase problems with coagulation factors. It does not increase the risk of blood clotting. So I'm not sure which research you read, but it's not accurate if it did in fact say that. And so no, I do not think that was the case. I think sometimes nature's a little too generous and it can be true and not related. The next question comes from Jody Clark.
Actually, Dr. Boster, we skipped Kelly Hertz at the top there.
Oh my goodness. I'm so sorry, Kelly. That was not done on purpose. Please forgive me. And thank you for keeping me honest, Chris.
Yes,
Kelly,
sir.
let's definitely do your question. Not done on purpose. Kelly writes in, does MS and symptoms progress over the years, even if your MRI stays basically the same? And the answer is yes, it does progress, even if your MRI stays the same. And I'm going to use an analogy, Kelly, to help you understand that. So imagine that I have a shotgun. Now, I don't own a firearm, but pretend that I have a shotgun. So boom, and I'm going to blow a hole in that wall. All right. So now there's a hole in that wall and we're going to choose not to patch it. Right. And every time we walk by, I'll say, remember when Aaron lost it and blew a hole in that wall? Now, 20 years from now, when the building that I'm in ages and the materials in the building wear out, which wall falls first? The one with the structural damage. And unfortunately, lesions in the brain are somewhat similar. So if you have a lesion in your spinal cord, which causes a transverse myelitis, where you're numb from the waist down, and we give you steroids, and over time, fortunately, you get better. If I look at the MRI, you still have a lesion on your MRI. You've made a recovery functionally, but structurally, there's still damage. And if you look 10 to 15 years later, as your body ages and as your spinal cord ages, those areas can wear out. And we think that's where progression comes from. And so your question, Kelly, is very common. Doctor, you're telling me that my scans are stable. Yay. Doctor, you're telling me that I'm not having attacks. Yay. But why am I worse? And actually, if you log on to my YouTube channel, the front page, the video that's displayed there is called Why Am I Worse? And it addresses that exact question. So thank you for asking it. All right. So Chris, now I need you to keep me honest to make sure I don't skip around. Jody is the next one, I hope.
Jody's up next. Yeah.
All right. Super duper. Diagnosed with MS in April of 2022, being treated with Kesimpta. Blood work last month showed high levels of anti-MAG antibodies. Is this connected to MS and will Kesimpta treat both? Thank you. This is a complicated question, and it doesn't have enough information for me to provide an answer. So what we see here is someone who is diagnosed with MS, but I don't know how they got diagnosed. I also don't know what other autoantibodies were seen. And so this is the kind of situation where we would need to collect a bunch more info before I could say anything intelligent. Now, if we're dealing with an NMO spectrum disorder, a B cell depleter should work to treat it. And Kesimpta is a B cell depleter, but that's a very off-label comment because it has not been studied rigorously in clinical trials. The next patient that's asking a question is none other than Karen Weiss. That's a cool last name. Can you please explain the difference between SPMS and PPMS? Yes, the letter S and the letter P. That's the difference. Both of them are examples of progressive multiple sclerosis. So PMS means progressive multiple sclerosis. The S before SPMS means secondary progressive. So first off, the person had relapsing MS, and now they're starting to have some progression independent of relapses. So secondarily, they're having progression. The P in PPMS stands for primary. Someone with primary progressive MS starts progressing in disability without attacks from the first day of their diagnosis. So the difference between the two is the description, the phenotype that we take. Now, Jane is on, probably my favorite person in New Zealand. It's great to see you, Jane. I hope you and your hubby are doing wonderful. Thank you very much for joining. And please tell my tomorrow hello, since she's in New Zealand and it's tomorrow over there.
So let's so people who have joined us, it gives you a quick water break. So everyone who's joined us, thank you so much. And please put your questions into the Q&A. We have about 30 minutes left, 29 minutes, right on that. But we've answered a heck of a lot of questions already, and we got quite a few more to go. So Deborah's up next.
Awesome. And Chris, if I tend to be a bit long-winded as we get closer, feel free to say, hey, Aaron, pick up the pace, because I certainly don't want to cheat people out of answers.
Right. Yeah.
So Deborah's up. And I'm a little intimidated by the last name. So Deborah S. writes in a question: are there any specific examples of these medicines that you can mention for non-active secondary progression that you have found to be effective? Yes. So that's a very nice question. Follow up to the earlier question. I find using B cell depleters like Kesimpta, Ocrevus, Rituxan to be very appropriate. I think Mavenclad has a role. I think Limtrada has a role. I also think that Aubagio, interestingly enough, has a fantastic role, and that's a drug that I use in that position quite a bit. So Karen Weiss comes back with a follow-up question. And do you think there's a big difference in the efficacy between Ocrevus and Kesimpta? That is a really good question, which does not have an answer. Now, the reason it doesn't have an answer is because it's not been studied. Now, when I look at the data myself, I tend to have a sense that Ocrevus might be a higher dose or a higher concentration in the CNS, but I can't prove to you that that then results in higher efficacy. And so we don't have a head-to-head trial. And if I had to guess, I would guess that the medicines might be more similar than dissimilar, but that is a guess. Jim writes in and he says, do you have an update on disco research? Now, I want to make a funny joke and like dance around the room, Jim, but I don't have an update on the disco trial. And so I'm sorry that I can't update you on that trial. Disco trial is not about dancing. It's about multiple sclerosis. So
we do have a non-wine mouse again up at the
sorry,
top.
I missed the mouse. Sorry, Mr. Mouse or Mrs. Mouse. Is having a lesion in my brainstem, but not on my spine, a sign of poor prognosis? I haven't been diagnosed with MS yet. I'm waiting on my spinal tap. So anonymous, we're getting ahead of ourselves. And I'm not trying to be difficult. I just think, we don't want to get way ahead of ourselves. You're in the process of being diagnosed, but I think that's a fair question. And the answer is yes. So when we look at people with an MS diagnosis, if they present with an MRI, lesions in their spinal cord, which you don't have, or if they present with an MRI with lesions in the brainstem, which you do have, that's a risk factor for a more progressive or a more aggressive disease. Does that mean that you're doomed? No, not at all. It just means, at least in my shop, I'm going to come at you with a really high efficacy medicine because I'm not going to waste time, on something that's lower efficacy. Great question. Thank you. Okay, so now we're going to go on to Bev, and I'm so appreciative Chris is keeping me honest here. If you were newly diagnosed with relapsing MS at age 53, and your first flare-up has lasted a few months and is still happening, how do you know if these symptoms are permanent, if normal prior to the debilitating attack is the only baseline you have? So this is a very important question, because almost everyone who has MS struggles with a version of this question. What's the new normal? And if I have an attack and I haven't recovered, is this my new normal? And earlier, Bev, we had an anonymous question, I believe, where someone said that they had the symptoms and they lasted a year. And it's been my general experience that if you still have symptoms residual a year later, that might become your new normal. But if it's been earlier than a year, I think that you're still likely to have some type of recovery. And if you receive steroids and didn't respond, then it's time to treat with another course of steroids or Acthar or IVIG or ACTH or plasmapheresis. The point is, there's a host of things that we do if you haven't gotten better. And then we see Jane again, and this time she asks, what do you think of Tysabri and Ocrevus as injections rather than IV infusions? And I'm reminded that Jane is not in the United States because these therapies are not available in other formulations outside of intravenous in the US. But in Europe and maybe in New Zealand, they have some other formulations. Now, I have to be honest that I have not seen those data. The FDA did not see fit to approve sub-Q Tysabri here. And so I actually don't have any experience. I suspect that if the formulation is done correctly, that it would be equivalent because part of the point of making it a different route of administration is that they can still get adequate blood levels. But I have to be honest with you and say that I'm not up to date on that data since I can't prescribe those drugs in my country. Another mouse asked a question. How long does it take to know if Ocrevus is working for my multiple sclerosis? I've taken 3 doses so far with no new lesions and shrinking lesions on the MRI. So I love that question, mouse, because it's not like other conditions where, you have a head pain, you take an aspirin, then the head pain goes away, right? So that's a really easy cause and effect. With MS, we're dealing with a concept called therapeutic lag. LAG, therapeutic lag. Therapeutic lag means I do something today and I'm going to see the results of it in a couple of years. And so if I, for example, don't treat my disease today, I might be fine for a couple of years, but then later I'm going to pay the devil's price. And so it's true that when you start a medicine, it's very hard to say, okay, well, I started the medicine today and now I see an effect. We might be able to see an MRI effect within 3 or closer to 6 months. And I would submit, based on your question, that you are seeing an MRI effect. I also remind everyone listening that the natural history of MS, unfortunately, is to get worse over time. And so if you are not getting worse, if you are not having attacks, if you're not changing on your MRI and not changing on your exam, that's evidence of it's working, because that's beating the natural history of the disease. Great question. Thank you. Now, Joe has a question. Mr. Siders asks, Xanaflex, does it work as good, if not better, than baclofen? So Xanaflex and baclofen are both muscle relaxants, and we use them in multiple sclerosis to treat spasticity, spasms, cramps, Charlie horses, stiff legs and arms that are hard to bend. And I would say that baclofen and Xanaflex are my go-to drugs, but I don't use them in the same location. Now, Jeff, the first thing that I want to go over, Joe, is these drugs work differently. So baclofen is an analog of a neurotransmitter called GABA. GABA is the stop neurotransmitter. So when you swallow baclofen, you're swallowing the stop neurotransmitter. When you take Xanaflex, that's an alpha adrenergic drug. So it works completely differently. They both work on spasms and cramps and Charlie horses. I think that baclofen is less sedating by a long shot. And so I generally don't give people Xanaflex, tizanidine, during the daytime because it's too sedating, whereas baclofen seems to be a little bit better tolerated. I love to use Xanaflex at night, particularly when you're waking up with spasms and cramps, because I think it's really good at that. And the fact that it's sedating can help improve the quality of your sleep. So I think there's a role for both. I will say, Joe, that some people tend to respond really well to one and not the other, but I think that's kind of unique for that individual human being. Great question.
Dr. Boster, we have a question. It looks like it's from Shauna from Facebook. And she was asking, what about the monkeypox vaccine in MS? She is currently on Kesimpta.
So a couple things, and I'm not going to speak specifically about monkeypox, like the formulation of the vaccine, but say that it's an okay thing to do is if it's a dead virus, we're not worried. Okay, so we tend to avoid giving patients with MS a live virus because it could trigger an infection and an attack. And so giving someone a dead virus is the thing to do. And I would simply want to time it in the middle of the Kesimpta. So my own personal strategy when I'm giving someone a vaccine with Kesimpta is I skip a month of the shot. So they'll do the Kesimpta, a month later they do the vaccine, a month later they do their Kesimpta. Now, I'm not saying that's the right way to do it. That's just what works for me and my patients. That was a good question.
All right, so we have about 20 minutes left and 12 questions. So
okay, I can do it.
Yeah, you can do it. All right.
Here we go. Okay, so short answers, Aaron. So Camilla writes, I am scheduled to get my very first Tysabri infusion. Am I at risk of a relapse between now and then? No. I do not want you to think that way. Having a relapse is very, very unlikely. The statistical probability of having an attack off therapy is about one attack every 3 years. And so the likelihood that you have an attack in the next 2 weeks is very, very low. I would not waste any energy on that at all. So here we have a wonderful person, Desiree. How are you? Thank you for joining us tonight. And thank you for the following question. Is there any relationship with our disease-modifying therapy and in a risk of increased thyroid issues? That's a really good question. So for starters, interestingly, people impacted by MS have a high risk of thyroid disease, higher than the general population. People with MS, interestingly, it looks like they may have a higher risk of thyroid cancer even. And there are certain drugs which jack with your thyroid, not all of them. So for example, glutathione acetate, no impact on the thyroid. Aubagio, no impact on the thyroid. Rebif, Betaseron, Extavia, Plegridy, Avonex can affect the thyroid. Limtrada can affect the thyroid. So it's very specific which drugs do and which drugs don't. A non-Y mouse writes regarding water. Is seltzer water okay? This is seltzer water. Brands like Waterloo and something else that don't have any added artificial sweeteners or additives. I need a beverage that has some flavor throughout the day. So actually, Anonymous, I 1,000,000% agree with you. My choice of beverage is Kroger's seltzer water. I love this stuff. I think that if it takes you drinking seltzer water to up your water game, I'm all for it. That's my secret sauce. I drink seltzer water. A couple things that we need to be potentially careful of. Inside this can is a bunch of chemicals that are lining the inside of the can. And there's a discussion about whether or not when the cans get heated up, whether any of those chemicals leach into the water. And I don't know if that's the problem, and I'm still drinking this stuff, but I've just heard discussions about that. Also, there's some discussions that if you have excessive amounts of carbonated beverages, that it could accelerate bone loss, but I think you would really, really have to go hog wild. And so my opinion, as evidenced by what you see in my hand, is I think drinking seltzer water as a way of upping your water game is great. Now, be careful because other bubbly waters like tonic water, they have sugars and stuff in them. So seltzer is the way to go. Michael writes in, I have major fatigue, but lack of sleep is horrible. The most sleep I can get at one time during the night is maybe 2 hours. Most nights I don't sleep before 3 or 5 hours a night. Help. just got a prescription of trazodone, but adding another drug just frustrates me. So this is a very, very common situation, Michael. And in the interest of time, I'm going to direct you to my YouTube channel. You're going to find a bunch of videos on sleep hygiene and ways of improving sleep. What I would submit to you is that trazodone can be helpful. That's like Bugs Bunny smacking you on the head with a hammer. But I think that there needs to be an important discussion about sleep behaviors, because I bet $1 that we could optimize your sleep behaviors and make some changes which would help you sleep longer. And so definitely look at those YouTube videos. Anonymous attendee writes in, why does stuttering and word recall happen at times and then not at all at times? So those are two different things. Oftentimes stuttering is not a neurological problem. It can be seen when we get anxious, and there's some people that have a stuttering problem where, they'll stutter a whole bunch. Oftentimes they become more intense when they become anxious. Now, word finding difficulties, which is part of the cognitive fog that we can see in MS, can also be exacerbated under certain circumstances. For example, when you're overtired, when you're overheated, or when you're under stress. So you can imagine that there could be one portion of the day where you're thinking clearly, and then another portion where you're not thinking so clearly. And that can be really frustrating. It's frustrating because sometimes people around you will think that you are not being honest, or, well, you seemed fine an hour ago. Well, you were fine an hour ago and now you're not. That's real. A different anonymous attendee, or maybe the same anonymous attendee, I can't tell, writes, is there a correlation between the number of oligoclonal bands and the severity of prognosis? And the answer is yes, there is a correlation. The presence of bands is an independent risk factor for more aggressive disease. And there is some literature that suggests more is not good. Now, Lori writes in, do you have anything for those of us 65 years old? Yes, I have lots of things. So I am not ageist. And as long as you have an immune system that's attacking your nervous system, and as long as you have nervous functions that you enjoy, like swallowing, orgasming, peeing, seeing, itching, like whatever you may want to do, I want to keep the immune system away from attacking the nervous system. Now, it's true that at 65, you're 10 years older than 55, and you may start to have your immune system slow down a little bit, but you still have MS. And so I wouldn't take away your therapy. I may de-escalate your therapy to something that has a nice side effect profile, but I wouldn't stop treating you at 65. In fact, I think stopping treatment at 65 is a devastating idea. Joanne,
we do have go back to the top there. We do have an anonymous, another anonymous.
Thank you.
Yeah.
Anonymous attendee number 8 writes in, also, why can a person get sharp knife-like pains in their ear at night? And that's because MS can cause yucky stuff. And MS can cause lancinating pain, and it can be in your ear, it can be in your eye, it can be in your face. It's an example of neuropathic pain. And I want you to bring it to the attention of your doctor, because we have a pill for that ill. Joanne writes, thank you for your answers and your humor. Well, that's very nice of you. I have one last question, and that may be a far reach. I can't wait. Does MS cause a person to become silver-haired younger than people without MS? My son, 12 years old, wonders if it is him or the MS. It's your son. It's not the MS. So MS is not known to cause accelerated hair loss. It's not known to cause gray. That's not something that we typically associate with multiple sclerosis. There are some MS therapies that can cause transient thinning of the hair, but not gray. So I think that might be your son, and I'm teasing. All right. So Anne Bezek, that's a cool last name, Bezek, writes in, had transverse myelitis, then diagnosed with MS, on Ocrevus since diagnosis, currently have only transient hand tingling. Is it likely that disability will worsen even with no new lesions or relapses? If you play your cards right, you're taking your medicine and make sure that it's working, you're exercising as part of your lifestyle, you're supplementing vitamin D, you eat clean, you're getting adequate sleep, you're not smoking, then you could stand a very good chance of making your MS really boring. And that's what I want for you. So I just went over being 4 for 4 in your fight against MS, and that's absolutely what I think we need to be doing. Jim writes in, is there a myelin sheath repair pill in the works? Yes, several. Anonymous writes in, I was told after getting treated with IV steroids, I should wait for some time to have my spinal tap done to avoid false negatives. Is that true? No, it's not. So how long? Not true. Steroids don't make the bands go away. They can change the MRI appearance. And so I like to wait a month after the steroids before I get an MRI. So let's see here. Karen writes in, would you have your patients on Kesimpta skip a month for the COVID booster? Yes. But you need to talk to your doctor because your doctor might disagree with me. So I'm not suggesting you do that. I'm just telling you what I typically do in my clinic. Anonymous writes in, had transverse, whoops, I think I already read that. Sorry. So J Sierra writes in, is it typical to have a high white count when having an MS attack? I don't know that it's typical, but it's not uncommon. Of course, we kind of have to talk about what do you mean by high white count? So the upper limit of white count, say it's 12. If it's 13 or 14, I'm okay. If it's 25, I'm worried you have an infection. Michael says, thank you. You are absolutely welcome, my friend.
And we do have a question. It might be one that was already in here, but it's from Facebook.
Awesome.
From Sam, does the number of O bands found in CSF signify how aggressive or not your MS is?
Good question. And that is kind of related to one beforehand. It's a very good question. The presence of bands is an independent risk factor for more aggressive disease. And there's some data to suggest the higher number of bands, the worse it is, although that's not gospel. So Daniela writes, is it worth getting tested for food that causes allergies in order to avoid extra inflammation in the body? I have not made that a recommendation. Do I think that there's value in avoiding like inflammatory foods and stuff? Probably, but I've never asked someone to get allergy testing. I'm not sure that it would make a difference, but I think it's an interesting question. So Margie writes in, Senator somebody had a shock of gray hair from the time he was a child, genetic. Okay, so did my grandma actually. She had like a white streak in her hair, even when she was a young girl, and people called her like a skunk. I think she looked fantastic. So last question of the evening.
Yeah,
Jim
we have
writes,
like 9 minutes, so you can go.
I love it. So Jim writes in, can you elaborate on research for myelin sheath pill? Not right now. I can't. It's too early for me to share data. So I can't do that. Now, we've got 9 more minutes, and I'm very hopeful that some of you can ask me some questions. So if you have a question on your mind, throw it in the chat or put it in the Facebook chat, and I would love to answer it.
Yeah. You knocked him out of the park there. The last. All right. Here we go.
Here's a mouse that writes, any thoughts on IVIG therapy? So IVIG stands for intravenous. So the first 2 letters are intravenous, like an IV in the arm. IG. IG stands for immunoglobulin, which is doctor talk for antibodies. So IVIG is a bag of other people's antibodies that we've pooled together, like thousands and thousands of donors. And we clean it so there's no hepatitis or HIV or any of that kind of stuff. And we can infuse these antibodies into your arm, into your vein. Now, when you flood the bloodstream with thousands and thousands upon thousands of antibodies, some of those antibodies are going to bind to your autoantibodies. And when they bind, it makes them not functional and they fall out of solution. So it literally is a way of clearing out autoantibodies, which is really neat. And it's an effective way of treating MS. So in the late 80s, early 90s, when we didn't have a lot of options, we used to use IVIG. And I still use IVIG in practice, but it's off-label and it's very, very expensive. And so it's hard to get. IVIG is an option for treating MS, and I think it's actually a pretty decent option. Karen writes in, is PPMS always a bad prognosis? Can you have mild PPMS? So generally speaking, in groups, it's worse prognostically to have PPMS than relapsing MS. That's in groups. You're not a groups, you're one human. And is it possible to have mild PPMS? Yes, it is possible to have mild PPMS. I have patients that have had PPMS for years and they are really involved in CrossFit and they run regularly. They live very full lives and work full time. So I think that it is possible. Camilla writes in, how common is hepatic autoimmune disease with an MS diagnosis? So that's an interesting question. If you have one autoimmune condition, MS is an example, you're much more likely to have a second autoimmune condition. And so autoimmune hepatitis is an example of that. Now, the most common secondary autoimmune that I see is thyroid, but hepatitis is possible. It's also possible that some of the MS drugs can cause a hepatitis. So D. O'Connor writes in, and I do see that question over from Amy, so I will get to that in just a second. By the end of this discussion, Chris will have me perfectly trained. So D writes in, if you have ear pain, word recall, exhaustion, and slurring, what's the best medicine to start? So again, we have to make a bunch of assumptions. I'm assuming that we're talking about multiple sclerosis. I'm assuming that we're on a disease-modifying therapy. I'm assuming that you're not having a disease activity, at which point then we can get into treating symptoms. So let's go over to Facebook, where Amy writes in, hi, Dr. Boster. Well, hello, Amy. For those recovering from COVID on top of MS relapses, what are you seeing in terms of how it affects recovery? So COVID is a nasty creature, and it doesn't abide by the rules that we've become familiar with, like we see with like flu, for example. And the COVID infection can trigger an attack. And if it doesn't trigger an attack, it most certainly can exacerbate baseline symptoms. And a lot of people with MS, unfortunately, develop what we refer to now as long COVID, where they have pathologic fatigue above and beyond what they're used to, and difficulty with smell and taste, and a persistent cough that can last for some time. It's very, very unpleasant and very frustrating. Now, some people have said to me, well, Dr. B, I don't want to get a COVID vaccine because I don't want it to trigger some symptoms. And I remind them that if you have COVID, it's going to trigger symptoms for a much, much longer period of time. Great question. Nadia writes in, hello. In your experience, is it bad for a person to take between 5,000 and 10,000 units of vitamin D daily? It really depends. It can be very bad or it can be very good. And it's all based on your level of vitamin D before you start. So I don't recommend just randomly taking a bunch of vitamin D. I think it's important to check a blood level of vitamin D 25-OH level. And based on that, I can recommend what supplementation to take. Now, if you don't know your level, I would not take 10,000 units because that might be an overdose. And you can actually hurt yourself by taking too much vitamin D. And so if you don't know the dose, taking closer to 4,000 is probably a little bit of a safer bet. Joe asks, how can I monitor my thyroid? So there's a couple different ways. The doctor can palpate the thyroid and make sure there's no lumps and bumps. And we can very easily draw laboratories. We can draw a thyroid panel, and it kind of gives us the entire playing field of the thyroid. Jay Sierra writes in, any thoughts on getting MS after COVID vaccine? I got MS 11 weeks after, thinking it opened the blood-brain barrier or something. So Jay Sierra, the first comment is that we don't know the answer because we don't actually know the answer. But the second comment is, I think you're onto something. And we do know, and there's been papers published, that after COVID, people can have neurological sequelae. And I have seen some people that presented with what looked like MS. And the best formulation that I had was they were going to present with MS, and this kind of tipped them over the scales. Maybe, like you suggested, opens up the blood-brain barrier. Fascinating question.
So it's Dr. Boster, we have about 3 minutes left. You can certainly go over, but I think we should probably cut off the questions at Marty and Sam over here.
Yeah, and I was told that I have to finish on time or I have to go in the naughty corner. So
go.
Let me try to tackle these really quick. We've got Kayla who says, hi, I've had numbness and weakness in my entire right side since my relapse, October of last year. Is it likely that it'll go away and the feeling will come back? So a year out, I'm concerned it might not, but I want you to aggressively involve yourself in physical therapy and see how much better you can make yourself. Sam, also from Facebook, right? Is it okay to take 1,000 milligrams of vitamin C every day? I wouldn't do that just arbitrarily because I want to know what your vitamin C level is. Going over to the anonymous section, I'm teasing. There's just a lot of anonymous attendees. Elaborate more on over 65 treatment. I have multiple YouTube videos on treating old people in MS. I say that in quotes. And so go to that video and you can see me talk about it ad nauseum. Jody writes in, thank you for your time. You're very welcome, Jody. It's my honor. My MRI showed no lesions during the diagnosis. However, CSF showed high levels of IgG index. So the doctor diagnosed me with MS. Is that common? No. It's not common to be given an MS diagnosis in the complete absence of lesions. That's a little bit uncommon. So Anonymous writes, does Tysabri increase the risk of complications from COVID? No, not at all. That's one of the fantastic things about Tysabri during the pandemic. And the last question of the evening from Margie, does InterStim Medtronic work for MS bladder? Yes, it does. Is it worth it to get at age 72? Yeah. I mean, if you don't want to be incontinent of urine, I think that doing things to stop it is fantastic. And if bladder Botox isn't cutting it, the nice thing about a bladder stimulator is you can test drive it. They'll put the bladder stimulator in and you'll see if it works or not. And if you like it, then you can keep it. And if you don't like it, you can pull it out. My name's Aaron Boster. And as always, thank you for learning about MS with me. It's such an honor to be here with MS Focus. This is a fantastic organization. So I want to thank you guys for hosting us. And I want to thank everyone that participated with your awesome questions. It was fantastic.
Yeah, we answered, we got through it. Thank you so much, Dr. Boster. It was
my pleasure.
Always great to see you. And hopefully we can do this again. It's a lot of fun.
I'm looking forward to
it. I do see one coming up in November. I do see another one of these on the schedule.
Well, I will look forward to all of you coming. Please bring your questions and we'll do this again. I suspect that my good friend down in Atlanta from Shepherd is going to be doing something in October. Is he on the schedule?
He's going to be doing something in October 11th. Yep.
So October 11th, you guys want to tune in. You have none other than arguably the coolest MS dynamo who masquerades as a pirate sometimes in existence, a smart gentleman and a good friend of mine. So Ben Thrower is going to be doing a presentation in a month and you don't want to miss his presentations because the guy's a genius.
Yeah, I think he's a full-time pirate and part-time doctor.
There you go. There you go.
Yeah.
Take care, everybody.
Yeah. Thank you so much. We do have another Zoom next Thursday. Our next one will be with Christine Hampton doing the secret symptoms of bladder and bowel dysfunction in MS. For those who want to join, it will be at 5 o'clock Thursday, September 22nd. So thank you guys so much for attending. Enjoy the rest of your night. And we'll see you again soon.